Hello, everybody. Starting with number 7, outpatient and primary care services. As always, make sure that you look at the learning objectives and ensure that you understand what these are and ask any questions if you don't along the way. So when we start getting to here, the first thing that we want to really pay attention to is the terms outpatient and ambulatory care. They are used interchangeably in the world. Remember that ambulatory care is anything for a walking patient. So it can be diagnostic, therapeutic, or treatments provided to somebody who walks in. All right. Hospitals provide the majority of outpatient care, which may surprise us because obviously we think that they provide the majority of inpatient care because the patient is in the hospital. So we'll talk about that in a minute. Independent providers are struggling. They need to sort of group together, and I'm sure you've seen this happening. One of the greatest things was in Westchester, where one of the biggest changes were that they had literally almost one medical care provider that provided all services regardless of where it went. And so that was an interesting thing. It's difficult for you to be an independent provider because of financial reasons. The consumer demand fueled the growth of complementary and alternative medicine. One of the most interesting things here is that with technology and the internet, we've now understood and have a greater knowledge of what complementary and alternative medicines are. And people are taking a stand against maybe the traditional, here's my pain, here's my medicine, let's treat that, and not really looking at the whole person. So it really is interesting. And then, of course, the ACA tries to talk about the indigent and most vulnerable people in our community. That's one of the goals of that, and you can determine if and how you think that's working. This slide right here is very interesting because it actually tells us, and obviously table 7.1, it tells us about what's sort of happening and what's going on and how healthcare facilities have changed over the last probably 25 years. For some of you, I realize that you've never known anything different. And then for some of us who are older, you would have seen different things. And so in the past, sort of, what was happening and what's going on now versus now and what's happening. So some interesting things. You will note that the first 4 categories remain the same: home healthcare agencies, community healthcare agencies, hospitals, and independent physicians, practitioners are all in there. When you start to take a look at some of the other things now and what's going on in the present about what's going on, you'll see some big changes. Some of the most interesting things are when we talk about the retail clinics within medicine and what's happening and what's going on there. Who can get surgery and where can you get surgery? That's interesting. You can literally go to an outpatient retail place to have certain surgeries done. And sometimes it is, of course, surgeries where we are not medically necessary treatments. Some of the really important things that we note now is that we have specialty care outside of the system where it may not have been and is actually more accessible to many people. So that includes like the chemotherapy and radiation, dialysis, most diagnostic imaging centers, and some of which are even mobile. I love, of course, and you will know this because I am a huge fan of the fitness and wellness centers and how we're incorporating that into it, as well as some of the occupational health centers and sports medicine. So those things are really exciting. When you talk about the rehabilitation, psychiatric outpatient, again, allowing more people to be able to have access to those types of things. And then the real specializations when it comes down to things like the hand injury rehabilitation and even back injury rehabilitation or pain management things that are fairly new in our medical world. Women's health clinics are interesting, and now we're even developing since then, transgender health clinics and specialty situations along those lines. And then from there, you'll probably note that other things are happening in our world. One of the key things in this chapter, of course, is what's the difference between primary care, secondary care, and tertiary care. And so this slide and these next 3 slides really show you that. So the primary care is the person who's sort of the stopgap, the person that you know well, the person that has your medical records, and this is the person that you sort of go to and talk with and maybe have your well checkups, and your family goes there. The secondary or secondary care is usually the consult with a specialist. Maybe you're having a problem or an issue. Routine surgery, maybe knee injury or something along those lines. Even as far as, we might say cardiac rehabilitation and that type of thing, because of course those are routine at this point in time. And then the real things are the rehabilitation. So OT, PT, speech therapy, those types of things that, and cardiac rehab, all of those things are sort of in that secondary care. And then when we get to the tertiary care, this is where it's the next level up, and these are highly, highly specialized folks, technology driven. These are some of the things that you might be see going on with genomes. You might be see going on with some of the new adaptive stuff. Now, as I said before in the previous one, that cardiac surgeries may be secondary, but also some of the new transplants and some of the new ways that we're doing that, and orthopedics can certainly be tertiary care. Taking a look at some of the ways in which we're treating tumors and the like go into that. And while it says it's technically driven and highly specialized, you will also see that these types of care providers are typically found at large research hospitals. So that's the thing to look for in that area. So back in 1978, the World Health Organization decided that they were going to come up with some sort of definition for what primary health care was. And the reason for that is because they wanted to make sure that it was based off of the principles of equity, participation, intersectional action, and making sure that the appropriate technology played a role in the healthcare system and what was going on across the world, not just in one place. And so they started to talk about some sort of point of entry. So the primary care was the point of entry where people would come in, and this individual family practitioner, internist, they would come in and they would take a look at what was going on, and then they would either treat it or push it to the next level, if you will. They served as a coordinating person of care. Who and what was next and what should you do next? And then, of course, they provided that essential care on a day-to-day basis of what happened and what you needed. Understanding the imperative or critical role that primary care providers played in health and wellness of the people, the Affordable Health Care Act decided to make some basic provisions to increase that and to increase people's coverage and utilization of these things. So first and foremost, they increased the Medicare and Medicaid payments. They provided new incentives for primary care providers to work with those most vulnerable and unserviced areas of people. As far as even, where you had your practice, what type of patients you did. They expanded healthcare programs all over so that more people literally had access. And then they created these additional training programs at certain colleges and universities where they paid for people to begin studying in certain fields. And so if you had agreed to practice in a certain area and you agreed to study a certain discipline, then there were funding, and there still is in some cases funding for certain programs related to healthcare and the great need things. Something really interesting and to something to pay close attention to is some of the new directions in primary care. So they're talking about some really interesting things. And maybe where we'll grow and where you'll see innovation happening in medicine across the world. And so taking a look at some of these things where we talked about technology in the previous chapters, you can take a look at some of the, patient-centered medical homes. You can take a look at what's going on in the community-oriented care elements. This is probably what's really important to us as public health providers. What can we do and what can happen from a larger scale? Everything need not be based on an individual one-on-one, but if they need that, how do we help them do that? And so from there, we want to start to talk about what's, who the primary care providers are and what goes on and what we need. Please take a few minutes to look at and understand what some of the new primary care facilities are and where we're trying to grow with those. But really, for the rest of this discussion and for this part of the class chapter, I want to talk about complementary and alternative medicines. And so from the standpoint of, we call it CAM, and if you take a look on the National Institutes of Health, you will see that there is a CAM directive. There's actually a whole chart of what they are and what happens. And so the National Center for Complementary and Alternative Medicine has a specific objectives that you want to take into consideration. First and foremost, what are some of those things that can actually create better environment and healing? We still, please understand, follow the rigorous scientific process. Things must be evidence-based. Lots of people tend to think that CAM are sort of hokey and psychological or ridiculous. And so I want to keep in mind that the things that you'll find here are still undergo rigorous scientific evaluation and are evidence-based. So that's important to keep in mind. We still have a whole lot of training to do and a whole lot of building in this area for research and development. It's something that's really important to keep in mind. And so who and where do we share this information with and who can we talk to about it is critical. I touched on a few points before where we talked about why CAM has grown and why people are more interested in it. And so again, because we as a population are being more educated and we can find more information out through our own queries or just interest. And so we started to take a look at, the traditional medicine isn't helping. The ways in which we live, our lifestyle isn't helping. So we want to avoid different types of surgeries that we don't need to have that may put us in a long-term or change our function. We want to take into consideration that the medication that we take, when you start to look at the different side effects of medicine are oftentimes worse than the literal benefit of taking it or the problem in which they're trying to cure. So that's one of the things. Again, people want to feel in control and empowered by doing something different. And we're finding that because of the system, and I don't want to disparage any healthcare provider, but because of the system and the way that it goes, there's less and less time for patient practitioner relationship building, and there's less and less time for listening. And so again, we go back to that sort of, okay, what is your chief complaint? Here's what I'm going to do to take care of it. Instead of understanding that my chief complaint may be these recurring migraines, but I have so much stress in my life, this, and this is going on, and I am always tense and not eating healthy, not exercising, and it's sort of that bigger picture that is not being taken care of. I'll just finish in our quick little 15-minute time frame here with the encouragement for you to take a look at what primary care looks like in some other countries. We're continually trying to figure out how we can do it better, and we are comparing ourselves to other countries, other places. And good, bad, or indifferent, it's important to sort of take a look at how they do things. Size matters, and we really want to take a sort of deeper look into it. The United Kingdom has some really interesting processes and way that they do things. Canada also does, but you want to be clear that in Canada, if you need a specialist, there's a great deal of timing. Australia, New Zealand, and Germany have all sorts of different unique programs in the way that they do their coverage. And then when you take a look at Switzerland and the US, along with Australia, Canada, France, and Germany, we have these shared payments. And so when you start to take a look at some of the privatized countries, Iceland, Sweden, you want to take a good hard look at, again, how we would scale certain things that they do well, and kind of what their issues are versus what our issues are. And while we may think that healthcare is healthcare, it really is interesting how maybe it isn't. So I just wanted to open your eyes up to that and have you take a look at that. Okay, so have a great week. Thanks.